And when we put lidocaine under the conjunctiva, you see this sign. What we made? We cut the conjunctiva around the avascular bleb and take out the avascular bleb, as we see in the video. And we move the conjunctiva to the limbus and suture this. And we make the solution of this problem. Of course, first we made treatment with antibiotics 2 weeks before the surgery. You see, before and after the surgery, when we move the conjunctiva to the limbus, we put sutures there, and you see after the surgery in the right picture. And the chamber formed after the surgery. You see in the first videos a shallow chamber, and in the videos after that you see a good chamber with a cataract, of course, and 3 months after we made cataract surgery with good results for the patient, and the visual acuity improved a lot. Thank you very much, and I show a new sign, Gator sign. Thank you very much.
Carlos Luis Chacón. Secondary glaucoma post-LASIK and posterior subcapsular cataract resolution. I present to you the case of a 32-year-old woman who consults in February 2021. Her main symptoms were headache, irritation, and eye pain, decrease in visual acuity, accompanied by dazzle lights at night and sunlight. In 2013, LASIK surgery was performed on both eyes. It is treated with topical antibiotics and fluorometholone drops. Intramuscular dexamethasone is applied. Keeps topical dexamethasone for several months. In April 2020, it begins with red eyes accompanied by an exaggerated photophobia. Consulted with a doctor and prescribes loteprednol drops every 8 hours. She receives loperamide 0.2% drops for presenting basic allergic conjunctivitis. In January 2021, debut with high intraocular pressure. The patient was prescribed for a triple combination of timolol, brimonidine, dorzolamide, and then they add latanoprost. In February 2021, the patient consults us for the first time. Visual acuity OD 2040, OS 2030. Intraocular pressure OD 24 milligrams mercury, OS 24 milligrams mercury. Biomicroscopy OD cataract subcapsular posterior, OS cataract subcapsular posterior. Ocular fundus OD 0.7 excavation, OS 0.7 excavation. Treatment timolol brimonidine, dorzolamide, latanoprost. Here we can observe the posterior subcapsular opacity in both crystallines. The ionoscopic pigment is observed on the trabeculum and areas of high insertion of the iris. Structurally, we can observe the optic nerve with an enlarged excavation and an asymmetric neuroretinal ring. In this image of the forum, we can observe a compilation of studies in which we can see the decrease in the volume of optical nerve fibers, with zones of injury of the ganglion cells of the macular area. Scotoma areas are present, showing reaction of the visual field. We used the Pentacam with a cataract pre-op program to look at the corneal aberrations and determine what type of lenses is possible to use. Using the ILO Master 700 and several intraocular lens calculations, we finally determined the type of lenses we can implement. I decided to perform combined cataract and glaucoma surgery using the femtosecond laser with an accuracy of IQ vividity in intraocular lens. And for the glaucoma, he performed an EPNP and mitomycin surgery. Here we can see a sequence in the upper part. The application of laser at the femtosecond of cataract with the extraction of the crystalline with ultrasound, the placement of the intraocular lens, and later the closure of the pupil with myostat. In the bottom part, we sequentially observe the EPNP surgery seen in the first image, the carving of the second flap with the discharging of the Schlemm channel, and the extraction of the disseminate trabecular membrane. Finally, the closing of the flap scleral with the nylon 10O and the conjunctiva. On the first post-operative day, we can observe the camera form with an IOL center, and we can see the reflex of the IOL vividity. The EPNP surgery does not form a visible blister after its surgery. Those are post-operative stigmatic alterations. These are immediate post-operative images. In June 4 of 2021, visual acuity OD 2040, OS 2030. Visual acuity with correction OD 2020, OS 2025. Intraocular pressure OD 13 milligrams mercury, OS 12 milligrams mercury without medication. Femtophaco because of secondary to steroids, posterior subcapsular cataract. EPNP surgery for non-controlled glaucoma with top medical therapy. Visual improvement is given without glare problems with IOL vividity. After EPNP surgery without medication, we have the control of the ocular pressure, IOP. Thank you.
Hello, everyone. I'm Alejandro Valencia from Medellin, Colombia. I'm going to share with you a case with glaucoma, malignant glaucoma. I have no financial interest in this case. This is a patient, 60 years old, female, who presented in our clinic 5 years ago with narrow angle, and the narrow angle was still closer after a PI. The surgeon at that moment considered to do a clear lens extraction to improve the risk of glaucoma in a very short eye and an intraocular lens with 28 dioptria. Phaco was done and 4 years ago, both out without any complications. But 1 year ago, the patient started with some feeling of losing far distant vision. And in the last 6 months, painful eye headache. She presented in the beginning of this year with intraocular pressure of 48 and 42 millimeters of mercury. Initially, one surgeon considered to do first a capsulotomy and anterior visualisis without success. Patient was on maximum medical therapy with Timolol, Vimonidine, dorzolamide, and Bimatopros, and the pressure was on 24 and 23 millimeters of mercury. In my office, the refraction was myopia in both eyes, worse in the left eye, bilateral peripheral iris touch in a shallow chamber, both eyes, bilateral anterior displacement of the IOL, and bilateral posterior central capsule. This is the picture of the fundus. It shows a very cooked disc in both eyes, but not too bad. The OCT showed a damage, bilateral damage, very symmetrical, and a total thickness 29 and 28, but I think this is artifact because the thickness of the vessels. This is the visual field, a really bad case with a very small visual island of vision in both eyes, worse in the right eye, and a little bit better in the left eye. Well, I had to do a decision in a very high-risk patient with a very high risk of blindness in both eyes, and most of the people do a total posterior vitrectomy with iridectomy, sonolectomy, and maybe a glaucoma implant device. Well, we consider many things. I also consider cyclos, G6 endocyclos, but I did, because I've been doing a limbal posterior vitrectomy for many years. I consider to do a trabeculectomy plus limbal posterior vitrectomy, iridectomy, and sonolectomy. I'll show you how it is. This is the video. This is a video. I'm trying to show you first the shallow chamber with transillumination. In this case, we show the chamber is really shallow. After doing that, the fornix-based incision for a trap, put some mitomycin C for 1 minute and a 0.5 concentration. Then I'll do this scleral, and I do the washing of the eye with the mitomycin, and then I'll do the scleral incision of the trap. It's a conventional trap. First the surface, and then the tunnel with a blade. Okay, but in this point, this is the most important part of the surgery: is where to do the limbal incision for the posterior vitrectomy. You have to put some light in the eye to get fancy illumination, and in the boundaries of the ciliary body, you have to cut the sclera to get into the space of the vitreous. Then, an paracentesis in the anterior chamber to put continual irrigation with a Lewicki cannula, and after that we can start the vitrectomy. I use a 25 gauge vitrector with and the posterior vitrectomy configuration. With the posterior. Cortemos aquí, hacemos una pausa y repetimos desde acá. Start. After that, I get into the eye with a 25 gauge vitrector with 5,000 cuts by second and 150 rate of aspiration to get into the eye. First, I do iridectomy, then sonolectomy, and then a wide anterior vitrectomy. Slowly and complete. It takes time, almost 5-8 minutes of vitrectomy, slowly. If you want, you can use triamcinolone if you like, but I don't use it. And then with movements of forward, we move and walk back and forward movement, I put the vitreous, the sonula around the hole I'm doing with the vitrector. The critical point where I'm sure the vitrectomy is complete is when I put some water in the anterior chamber, closing the irrigation, and if the chamber is stable, I think the vitrectomy is complete. If not, if the chamber is still shallow or gets shallow after the anterior irrigation, I have to do more vitrectomy. It's very important that not vitreous is in the incision. Then I put a stitch in the incision, just one stitch with nylon 10-0, and then I do the normal trabeculectomy. The conventional trabeculectomy. This is the iridectomy with the iridectomy, and then the stitches, and then the closing of the wound normally, and that's it. This is the chamber, a very, very wide chamber. It's not shallow now. And in the end, the one closer is really good. And the chamber is very stable with GS10. Okay. This is the result after the surgery. And the pressure now is on 13 and 11. Yesterday, with terzolamine, both eyes twice a day. The refraction is not myopia. The right eye is +1 and the left eye is 0, with some astigmatism that was before this surgery and is a little bit worse because the stitch of the sclera. Patient is feeling good. Patient relieved the symptoms, no pain. Patient is happy. The blade looks good with very, very diffuse blade and posterior. And this is the aspect of the anterior chamber, very deep chamber in both eyes. Thank you very much. This is the case. Thank you for the invitation.
Well, I'm Dr. Angela Rosa. I work in Edgardo Rebolletti Martin Hospital National. It is in Lima, Peru. I talk today about scleromalacia and glaucoma. I don't have any conflict of interest to declare. I start with a clinical case. I have a patient, male of 76 years old, no background of interest. He has a diagnosis of glaucoma 3 years ago in a maximum therapy, and he used of prednisolone sporadic. In the examination, we found a best corrected visual acuity of 20/100 in the right eye and 20/200 in the left eye. The IOP is very elevated, 36 in the right eye and 48 in the left eye. We can find scleral slimming zones in 360 grades, and in the gonioscopy, we can find abundant synechia in all 4 quadrants and abundant pigmentation at the level of the trabecular mesh wall. So we can see in the pictures the choroid shows through the scleral fin because the sclera is very, very thin. Well, the necrotic sign, scleritis, and uveitis in general can present multiple complications, especially in glaucoma. And what is the origin of this problem? Well, 5 items: the scleral inflammation and its approach to the trabecular mesh wall, the long time that this patient used steroids, the same uveitic process, the formation of the peripheral anterior synechia with the trabecular mesh wall dysfunction, and in severe scleritis, the destruction of the collecting canals due to edema. Well, we have to consider the deficit of tissue, the conjunctival tissue. Maybe we can use the contralateral eye in some case. We have to consider too the risk of the induced scleritis when we do the surgery, and it's important to maintain stable inflammatory markers in the post-operative period, especially the C-reactive protein and erythrocyte sedimentation rate. Well, how? When the use of corticosteroids or maybe the medication that the patient use for background disease. Well, we have surgical therapeutic options. I choose the FACO first, plus maybe the Drenai device implant, or GAD, or endocyclophotocoagulation. If we can use the Drenai device, we have to use heterologous scleral patch, or pericardium, or fascia lata, or dura mater. Where we choose the Drenai device, we have 2 options more, or use valvulate device or no valvulate device. The valvulate device is very important for glaucoma, but the no valvulate device is very, very good option. But the valvulate device is important for uveitic glaucoma. When we have a uveitic glaucoma, I prefer use AMET, valvulate device, AMET. Why? Because we have to risk of low pressure in this case of patient due to decreased function of ciliary body. When we can see the surgery, we use subconjunctival anesthesia. Then we do a pocket, make the pocket under conjunctiva to put the plate of the AMET. Then we fixate the AMET. We have to special consideration when we put the fixation sutures of the plate with nylon A0, very special. Why the scleral is very thin. Next we do the FACO like habitual. And next FACO we enter to the anterior chamber with 23 gauge needle, and next put the tube in the anterior chamber and fixate the tube with a nylon tensor. Next, we put the scleral patch. I recommended use only the 50% of the wall of the scleral patch. We can reduce this, and after that, we put the conjunctiva over the scleral patch. Well, this is the video. This is the post-operative. I can see that the receptor tissue is very good. And in the UVM, we can see that the position of the tube is parallel to the iris. It's a good location. And in this picture, we can see that the left eye is okay. And in the right eye, we choose the option of do a phacoemulsification plus gonial synecholysis with viscoelastic, and we have a good result. And the specular microscopy is okay in both eyes. In the eye fondos, we can find peripapillary atrophy. And the final IOP is 12 millimeters in both eyes with thymolol and brimonidine, and the best corrected visual acuity final is 20/40 in both eyes. Well, we have other case. We have a patient male of 40 years in studies of rheumatology 40 years ago, but don't have any medication, any habitual medication. Refers progressive low vision, referred to our hospital for uncontrolled glaucoma. He lost of the right eye in an accident and only have the left eye. And in the left eye, we can find best corrected visual acuity of 20/30, and the IOP is very high and is in 45 millimeters with maximum therapy. In the photograph, we can see the scleral thinning in 360 grades. Okay, and in the visual field, we found island of vision. Well, we do the same surgery, but in the inferior nasal quadrant. We can see that it's okay, it's very okay. And in the result, the patient has an IOP of 14 millimeters with thymolol and brimonidine. And the best correct visual acuity is 20/40 in the left eye. It's a good result, I think. And in the final case, final case number 3, we have a patient female of 50 years old with background of rheumatoid arthritis. The important in this case is that the patient had an scleritis episode in 2017. And we can see in the examination that there's a difference between both eyes. In the left eye is healthy, and in the right eye, we can find a low vision and a very high IOP, 46 millimeters with maximum therapy. Well, we found scleral thinning areas in 360 grades, and in the gonioscopy, we found abundant pigmentation and abundant synechia. Well, we can see the difference between two eyes. The left eye is very healthy, and in the right eye, we choose put the valve, AMET valve, in the superior temporal quadrant. We can see that in the other quadrant is very thin, the sclera, and we can see the color shows through. We can have especially care when we fixate the plate, when we put the suture. The left eye is very healthy. and the specular microscopy is okay in both eyes. And in the eye fundus, we found a difference between two nerve optics. The left nerve optic is very healthy, and the right nerve optics have a damage. Well, the IOP final is 11 millimeters with timolol in the right eye. The left eye don't use medication, and the best correct visual field is 20 over 100 in the right eye. It's okay. The follow-up of the three patients is about 2 years, and he has good evolution. Well, we have many roads to do in these patients. We can do the FACO plus 9 device, we can do the FACO plus GAD, we can do some doctors, we can do the FACO plus endocyclophotocoagulation. The most important is the success in the patient. Well, thanks a lot. Thanks a lot. It's all.
And you're live. Go ahead.
Thank you for the speakers for sharing your experiences in glaucoma during this session. We're going to begin with the question and answers section of this symposium. And we're going to begin with the first question that we have here. Dr. Valencia, why do you prefer limba vitrectomy and not partial vitrectomy?
Because in this case, the risk was very high. And consider the risk on a vitrectomy in a very short eye and the risk to cause damage in the retina getting inside the eye. I prefer to do the limbal approach. I think was safer and was very effective, like in this case.
I have a question to Dr. Alejandro. For the treatment of malignant glaucoma, do you always prefer to make a combination of filtering surgery and iridectomy, vitrectomy, and sonectomy, or just doing the iridectomy, vitrectomy, and sonolectomy?
No, actually, this is the first case I'm doing both. And the case was because of a very symmetrical glaucoma, very interesting case because I never seen that. 4 or 5 years cataract extraction without any complication, and after that getting malignant glaucoma in both eyes at the same time. Really a typical case. And in this case, because the amount of the damage, the pressure, maximum pressure was on 48, 49. I don't think only doing a vitrectomy is enough. I think I needed more. I was thinking doing two, but I was not sure because I think in this method could be work. I would like in this case because the tool in the future I'm not sure is going to work as well and is working the trap. Maybe the trap is not working in the future as well because you had a vitrectomy and it is a high risk to failure. But I'm sure in this case, for the moment, it's a good option and it controls the pressure very well. After using 4 medication now, it's under 1 medication and the pressure is not too bad.
Thank you, Dr. Another question, Dr. Armando?
Yes, hi everybody. I have a question for Dr. Rodolfo Perez Guzman. In all the blade complication, do you usually do surgery or you may try medical treatment?
Yes. I use surgery only when there is a risk of infection. For example, say there, or sometimes if there is an exuberant bleb, a big bleb, or sometimes that goes to the cornea and the patient have pain and other symptoms like blurred vision. In that cases, I do surgery. I take out the avascular and move forward the conjunctiva, like in this case that I showed.
Okay, thank you, Dr. Rodolfo. Another question for Dr. Angela Rosa. No, what kind of glaucoma drainage device do you prefer use in these complicated cases?
Hello, Dr. Bauti. Thanks for the question. I prefer AMED in these cases because this case is also the uveitic glaucoma. But I think that, for example, verbal device is important to use in some type of cases because in these surgeries, the patients would IOP but with maximum therapy or with timolol with rumonidine. I think that if I use the verbal device, maybe the patient would get a good IOP without drops. Thank
you. Dr. Sandra.
Rodolfo, I have a question for you. When you repair the bleb, do you use mitomycin or 5-FU after repairing, or would you just go and repair it and that's all?
Well, in these cases, usually the sclera is with a lot of mitomycin. That's why the conjunctiva get avascular. And sometimes if you put new conjunctiva there, again, it can be avascular. But sometimes, could happen anything. So sometimes if you don't see better in the conjunctiva, you can inject 5-FU or maybe mitomycin. But all the area is impregnated with mitomycin. Usually it's not necessary.
Thank you.
For Carlos Luis, there is a really challenge for knowing for taking the real pressure, intraocular pressure in previous last year's practice. What do you prefer what tonometer do you prefer to use in patients with and previous LASIK surgery or corneal refractive surgery?
Well, I don't can't see the question. Can you repeat again the question because maybe.
We have a challenge always with patients with surgery, with refractive surgery. What type of tonometer do you use in these patients when you are suspicious of glaucoma?
In the past, I began to use a Pascal tonometer, and later I use a rebound tonometer. But in the clinic, we have a method to take the intraocular pressure with the equipment with the pentacam. We use we have a equipment together the pentacam to take the intraocular pressure. We made the think of the cornea and use this different kind of method to measure the intraocular pressure. I don't know if it's clear for that.
We have another question here in that audience. In the follow-up of your cases of valve and scleromalacia, did you observe an increase in expulsion of the plate more than without the scleromalacia? Dr. Angel Augusto.
Yeah, of course. No, I don't have any case of exposure. I don't know. I was lucky, but the patient had good evolution in 2 and 1 patient 3 years now. I see one patient 1 month ago, and he was very healthy. The implant. Thank you. Another question?
No, yes. No, we don't have more questions, but we have to end the session. We have just 19 seconds. Thank you for the attendings, for being with us this afternoon here in Ecuador. And to the speakers, again, thank you for joining this session and share your experiences with us. Thank you.
Thank you very much, Paola.
Thank you very much,
everyone.
Thank you. Thank you.